In medicine, not all information has the same weight. Some findings can completely change the diagnostic direction. These findings are called pivot data. In this unit, we will learn to recognize them, organize them chronologically, and transform them into a clear representation of the clinical problem. Clinical reasoning follows a sequence. First, we collect the patient's data. Then, we generate diagnostic hypotheses. Next, we select the necessary tests and interpret them. Finally, we reach the most probable diagnosis. At each step, we must integrate both subjective and objective information. What is a pivot data? A pivot data point is a clinical finding that decisively guides the diagnosis. It must be specific, relevant, and discriminative. For example, in a case of dyspnea, a sudden onset accompanied by an oxygen saturation of 84% is a pivot data point that forces us to think of a respiratory or cardiovascular emergency. These are the data that change our line of reasoning. Clinical information can be subjective or objective. Subjective information is what the patient reports, such as saying, "I have trouble breathing." Objective information is what the physician observes or measures, such as noting a low oxygen saturation or an elevated respiratory rate. A pivot data point may come from either of these two sources. Not all clinical data have the same weight. The physician must learn to distinguish what is relevant from what is accessory. In a case of dyspnea, low oxygen saturation and fever are more important than penicillin allergy, which will only become relevant later if we consider prescribing antibiotics. This discrimination avoids information overload and allows us to focus the diagnosis. The temporal evolution of symptoms critically guides the diagnosis. An acute condition, appearing within minutes, hours, or a few days, suggests causes such as pneumothorax, pulmonary embolism, or severe asthma attack. A subacute course, over days or weeks, may correspond to a respiratory infection or an inflammatory process. When it is chronic, lasting months or years, we think of diseases such as COPD or heart failure. Some symptoms follow a fluctuating or recurrent course, as in asthma, migraine, or epilepsy. In other cases, the course is progressive, with constant deterioration, as in chronic kidney failure or Alzheimer's disease. There are also relapsing remitting diseases, such as multiple sclerosis or lupus, which alternate crises with remissions. Finally, some presentations are fulminant, with sudden onset and very rapid outcome, such as severe sepsis or fulminant meningitis. Identifying the temporal pattern helps prioritize diagnostic hypotheses. To better communicate information, we use problem representation, a concise summary that includes age, sex, main symptom, and qualifiers. For example, a 32-year-old woman with sudden dyspnea, fever, and oxygen saturation of 84%. This format synthesizes what is relevant and facilitates clinical reasoning. A useful tool is to create a problem list. In our case, sudden dyspnea, oxygen saturation of 84%, fever of 38.2 degrees Celsius, history of asthma. By structuring information, we learn to group, prioritize, and discriminate. First, we place urgent or decisive findings, then relevant supporting data, and finally leave aside accessory information. For example, dry cough or penicillin allergy are not immediate pivot data, but they could be useful in later stages of reasoning. This exercise allows us to visualize connections and guide diagnostic hypotheses with greater precision. Illness scripts are mental frameworks that physicians build through experience. They include predisposing conditions, typical symptoms, findings, and disease progression. In the case of asthma, the script integrates family history, episodic dyspnea, triggers such as exercise or allergens, and reversibility with bronchodilator. Experts compare patient information with these scripts to generate differential diagnoses. In conclusion, pivot data guide us toward diagnostic hypotheses. Clinical chronology and problem representation organize the information clearly. Structured organization helps distinguish the relevant from the accessory. And illness scripts help us reason like an expert physician. By integrating these steps, we strengthen the development of clinical reasoning in medical students.